morning. We're going to discuss the final section of Unit 6, and that's going to be Chapter 11 and 12. So if you'll turn to Chapter 11 in your textbook, this chapter is about drugs that affect the immune system. And I realize these chapters are rather complicated and full of a lot of pathophysiology, a lot of difficult meds. So I've tried to simplify that both on the PowerPoint and through these lectures. And then I also highly encourage you to do your quizzes. And I believe I sent you an announcement saying that number one, I increased the number of questions on the quiz, and number two, I put the the length of time at 1 hour, and that should give you plenty of time to go over these quizzes. You will see this information again on your test, so I cannot highly encourage you enough to review these quizzes, look it up in the book, and try to grasp the information. So in this chapter 11, I need you to make sure you understand the terms. And as you see, there are quite a few terms in this chapter. Being acquired immunity, active immunity, what is an antibody, what is an antibody titer, and what is an antigen. So the difference that you need to learn is what is an antigen and what is an antibody. And an antibody titer, most of you probably have had those. It's a blood test in which you see the physician then can measure the presence of an antibody in your system. An example being chickenpox. Many people have never had the chickenpox, and so when you become a nurse, you have to say when you had the chickenpox. Well, you can have a titer, and a titer will identify whether you have those antibodies in your blood as to whether or not you were exposed and developed then antibodies, and but you never had the active disease with the pustules, that sort of thing. Anti-proliferative drugs, anti-rejection drugs, artificial acquired active immunity. So you need to know about immunities, active, passive immunities, artificially acquired, that sort of thing. Attenuated vaccine, what is an autoimmune disease, what's a biosynthetic vaccine, etc. So it's very important for you to master these terms and understand some of the pathophysiology behind them. Okay? Okay, so we're going to talk about true immunity is the ability of the body to recognize a specific organism when it reinvades or re-exposes itself to the body, and to take steps to remove and activate or destroy the invading organisms before illness can occur. The immune system helps you develop true immunity. So one being the chickenpox. This system can sometimes seem confusing because it did not house within one organ of the body. So it's systemic wide. Your true immunity becomes systemic wide. Acquired immunity is an adaptive or learned internal protection that results in long-term resistance to the effects of invading organisms. These responses are not automatic. Much of the acquired immunity occurs through the process of antibody formation by B cells and antibody actions. Any cell, product, or protein with a code different from your own enters your body, and it is recognized by the immune system. And it's recognized as being foreign, or it's an antigen. So remember, antigen is that foreign product that enters your body. And your body sees that. It sees there's something weird that's just entered my body. Usually the white blood cells are our first responders to this antigen. And then they bring with them unsynthesized lymphocytes, which are white blood cells. So they bring along with them our white blood cells. The T cell then helps the B cell learn exactly how the invading antigen's code is different from your code. And this is called sensitizing it. So the B cell is studying that foreign body in your body, and that has been brought with the lymphocytes. Then the B cells, remember the B cells are the ones that start making and releasing antibodies that will bind only to the cells or products that carry that specific invader's code. So the antigens come in, and then the white blood cells start announcing that there's an antigen. The T cells help the B cells recognize what that foreign invader is, and they then start releasing the antibodies. And that's our immune protectors. The antibody is a Y-shaped protein with areas on its arms that bind directly and tightly to anything that has the same specific code. So it goes in there then, and what the B cell has recognized, then that antibody with its little arms go and find that specific antigen. Other names for antibodies are immune globulins and immunoglobulins. Each B cell learns to make only one specific type of antibody that can only recognize and bind to that specific antigen. So again, just this little pathophysiology helps you understand the amazing, amazing thing our body is. It just never ceases to amaze me, down to the minute B cell in our body, how we are built and able to function. When you're invaded by chickenpox viruses and you actually get sick with the chickenpox, many fresh, unsensitized B cells in your body start learning to make anti-chickenpox antibodies. Not a lot of anti-chickenpox antibodies are made at this time, but the ones that are made are important in helping you get well within 5 to 10 days. So that's our immune system working. So you can continue to read all of that. Acquired true immunity provided by antibodies has several subtypes. These include naturally acquired immunity and artificially acquired immunity and passive immunity. Although all subtypes are helpful and provide some protection, they differ in how well they protect and how long that protection lasts. So we have naturally acquired immunity. That's the type of immunity started when a person's body is invaded by a foreign organism without assistance. So it's naturally acquired. If you're exposed, let's say, to the cold, that exposure is natural, and your immune system has the opportunity to develop immunity against the organism. Even though you may get sick with this exposure, your immunity system is still working. So naturally acquired refers to how the exposure to an invader occurs. This type of immunity can be active or passive. Active immunity means that your own body developed the antibodies. Naturally acquired active immunity is the type of antibody-mediated immunity that is started when you are invaded by a foreign organism without assistance, and your B cells then learn to make antibodies against the invaders. This type of immunity is the strongest and most long-lasting. It can provide good protection. That's why we talk about if a person's immunity is low, or if we are giving them a medication that can affect their immunity, or if their immunity is low and we're giving them then medication, we have to be cognizant of what other illnesses they've had in the past, and how their immune system is working. Naturally acquired passive immunity is the type of antibody-mediated immunity you acquire as an antibody transfers from your mother through the placenta and through breast milk. Your body didn't make these antibodies. This type of immunity is very important in helping to keep young infants healthy. but provides protection only for a matter of months, not years. And so that's why we encourage young mothers to breastfeed, so that they can get that naturally occurring but passive immunity along at least for a few months to protect them when they're babies. Artificially acquired immunity, although naturally acquired active immunity is the best type, sometimes we have to have artificially acquired immunity. For example, when a person catches diphtheria, he or she develops long-lasting immunity to it and will not get sick with diphtheria again. However, diphtheria has a high mortality rate, and some people who get the disease die. So artificially acquired active immunity is used to assist the body to learn to make anti-diphtheria antibodies without having to get sick with the disease. That's the reason when we travel, we may take a diphtheria vaccine. Artificially acquired active immunity is the type of antibody-mediated immunity that is started when an antigen is deliberately placed into the body to force your B cells to make specific antibodies against it. And this is common, certainly, in most countries with the widespread use of vaccination. So that's the most common way of getting artificially acquired active immunity. It's the deliberate injection of an organism or other antigen for the purposes of stimulating the B cells to produce the antibodies. And then you know what a vaccine is and what immunization. Different substances are used in the vaccine preparations. Sometimes inactivated organisms, usually virus or bacteria, are used. Inactivated vaccines contain organisms that could cause disease but have been killed or inactivated by heat, radiation, or chemicals from producing the disease. Examples of inactivated vaccines include those vaccines against influenza, cholera, and hepatitis A and rabies. Attenuated vaccines contain live organisms that have been modified so that they are no longer capable of reproducing, so they're not killed, or of causing disease, usually, but still retain their unique code. This type of vaccine is also called a live virus. Attenuating the organisms also makes them non-contagious, unless a person has very reduced immune functions. Examples of attenuated vaccines include those for mumps, measles, rubella, polio, chickenpox. And if you will look out over on the left-hand column on page 178, the 4 types of vaccines currently available are inactivated vaccines, attenuated vaccines, toxoids, and biosynthetic vaccines. Toxoids are vaccines that contain either a modified toxin that an organism produces or an actual part of the organism. And these can be tetanus, diphtheria, pertussis, which is whooping cough, HPV, and hepatitis B. Biosynthetic vaccines are those containing science-made substances that are very similar to parts of the virus or bacterium that can cause the disease. So biosynthetic, you know, that's something that has been chemically generated. Examples of these are against the influenza type B disease. Then we have vaccinating and boosting schedules. I will not ask you when vaccines are given or when boosters are given. You will learn that especially in your pediatrics course. But I do want you to review box 11.1, responsibilities when administering the vaccines. That's very important. How you store them, what you do before you administer them, what you do after you administer it. Now, and you can remember, usually when you get the flu shot, if you normally would see, if the nurse comes in the room, you will see her documenting. If you get them at CVS, something like that, you don't really see that nowadays. But the nurse would need to document the name and age of the patient, the name of the vaccine, the manufacturing lot number and expiration date, and you will see them look at that lot number so that they can track that vaccine. Why would they do that? If you were to have a severe allergic reaction, then you would need to be able, or the person administrating it would need to be able to document where that vaccine came from. So they document the manufacturer, the lot number, the expiration date, what dosage did they give, where did they give it, and what did the site look like before and after giving that, and other information there. But those are things that you would need to know as a nurse that you have to do. How you store the medicine, what do you do before you give the vaccine, and what do you do after. Very important. Artificially acquired passive immunity is the type of antibody-mediated immunity you would have if antibodies made by another person or animal were injected into your body. Because these antibodies are foreign to you, your immune system recognizes them as foreign and eliminates them quickly. For this reason, passive immunity provides only immediate, short-term protection against a specific antigen. It is mainly used when a person is exposed to a serious disease for which he or she has little or no actively acquired immunity. The injected antibodies are expected to inactivate the invading organisms. And then below are some examples of artificially acquired passive immunity. And tetanus is one, in which you also have to get a booster, but tetanus is one. Ebola. ROGAM is an actively acquired passive immunity, and we won't discuss that a lot, but ROGAM is given when a mother is Rh negative and she delivers an Rh positive baby. And some of those red blood cells can cross over in the placenta, and then that would be very harmful to the second birth. The first birth, the baby is usually okay, but the mother then is given a ROGAM immunity, so that if she gets pregnant again, that second baby is protected against those Rh negative red blood cells. So we won't discuss that a lot because you will learn that in maternity, but that is an example. Immunosuppressant therapy. The immune system, which is protective most of the time, can overreact and cause tissue damaging excessive responses. And so you hear about that nowadays, that people have an immunosuppressant disease. Some problems are acute and short-term, such as an allergic reaction, and other problems, especially autoimmune disorders, can be chronic and very destructive. For either category of problems, therapy with immunosuppressant drugs that inhibit or prevent optimal functioning of the immune system may be used. The autoimmune disease is a condition in which a person's immune system sees some of his or her own cells as foreign. So our system attacks our own healthy immune system. Our body just starts seeing that as something that is foreign, and so thus you hear about an autoimmune disease. Autoimmunity can develop against a specific tissue, component, or multiple components that are present in many organs or tissues related to widespread problems. An example is lupus, is an example of an autoimmune disease. Management depends on the organ, of course, or the organs affected. Transplantation immunology is for we give immunosuppressant drugs when there has been a transplant. I have an acquaintance currently that has just gotten a lung transplant, and he's 70 years old, but he got a lung transplant, which is unusual for someone 70 years old. But he's having to take a lot of autoimmune drugs, and they're very strong. They have many side effects, but they've learned over the years how important it is for transplant patients to take these autoimmune drugs. Type of immunosuppressant drugs, there are 4 types, and those are listed on page 184. Corticosteroids, which we have already studied. Disease-modifying anti-rheumatic drugs, which DMARDs we have already studied. Cytotoxic drugs, those are used to destroy cells, actually destroy cells, and that is chemotherapy. And selective immunosuppressants, and those are, they selectively target certain cells and products responsible for autoimmune disease. And the 4 categories of selective immunosuppressants. So you have 4 types of drugs, which we've just discussed: corticosteroids, DMARD, cytotoxic, and selective immunosuppressants. Those are the categories of drugs. Then in the selective immunosuppressants, you have anti-proliferatives, calcineurin inhibitors, monoclonal antibodies, and polyclonal antibodies. And this is where it starts getting a little bit deep in the pathophysiology. But the dosages are listed on starting on page 185, anti-proliferatives. And Azan is one. Imuran you hear about a lot. Then you have, I was trying to look at some of the most common ones that you hear about. Imuran's the one I hear about the most. So I don't believe I'm going to be asking you, I will go back and look if I will be asking you any of these really very specifics, but you do need to read this and understand. Monoclonal antibodies are used short-term for prevention of transplant rejection, as we talked about. Polyclonal are used for short-term for treatment of acute rejection episode that does not respond to the other types of therapy. So these are all drugs that are used specifically for rejection meds, and they go to specific cells, specific T cells in the body to prevent immunosuppression. Now you need to know there are certainly adverse effects, what to do before giving those, what to do after giving those. However, most of that will be given in a very high level big hospital, UT Southwestern or wherever in Dallas. But you do need to understand the basic understanding of antigens, antibodies, and how our body fights those through our immune system, and then what we've discussed. Key points, make sure you go over these key points and test yourself. But above all, you go through that quiz. Chapter 12 then, moving on, is anti-cancer drugs. And again, you have a lot of key terms: alkylating agents, antigenesis inhibitors, antimetabolites, antibiotic agents, anti-tumor antibiotics. What is cancer? Cancer, of course, is an abnormal cell growth, and it serves no purpose. It's invasive. It's without intervention, and without intervention, it would lead to death. It's just an abnormal cell growth. We certainly don't understand it. With all of our research, we're learning more about how to control it, but for some reason, our cells just start changing, and people developed cancer. It also can be called malignancy, and that's the term usually if it has spread. Carcinogen, any substance or event that can damage the DNA of a normal cell and cause cancer development. So you hear the term carcinogens. Certainly we know smoke is, we know asbestos is. There are many things nowadays that have been found to be carcinogenic. Extravasation, that is a term that I expect you all to know, and that is the leakage of fluid from that IV site that you've heard me talk about before into the skin. And many of the chemotherapy drugs are and other drugs are very harmful to the tissue and can cause serious tissue damage. And vesicants are drugs and chemicals that cause tissue damage on direct contact. And most chemotherapy drugs are considered vesicants. And normally at a hospital there is a team available if you, not you, but if the chemo drug is spilled, dropped, it is considered a hazard. And there is a team that comes. There's a special way to clean up a chemotherapy spill. When I first started nursing, we did give chemo drugs, and nurses don't now in hospitals the size of Corsicana, but we did give chemo, and we did have some spills, and we had a kit, a special kit that was used to help clean up that chemotherapy spill, and because it was considered a vesicant. So a cancer is an abnormal cell growth that we talked about that serves no useful purpose, is invasive, and without intervention would lead to death. It is a common health problem in North America, with more than 1.8 million people newly diagnosed each year. And I don't know if that's because we're finding out more about cancer, that we're able, I think certainly that we're able to diagnose it earlier, and that maybe there are more cancers because we have now shown we understand the body more, but 1.8 million people a year. The body cells are exposed to internal and external conditions that can cause the genes to change, like we've talked about. So once we have been exposed to a carcinogen, then our cells can change. And when there's overgrowth and spread outside of the normal tissue borders, that's when it has metastasized. So we've talked about carcinogens, the causes, we've talked about that, chemicals, physical agents, and certain viruses, like the HPA virus is considered, can cause cancer. Type of cancer treatment, chemotherapy is the treatment of cancer with chemical agents, which can increase survival over time, may cure the disease. The killing effect on cancer cells is related to the ability of the chemotherapy to damage the DNA of the cell and interfere with its division, so it kills it. Common cancer therapies include surgery, radiation, chemo, hormone manipulation, and targeted therapy. Unlike surgery and radiation, which are local therapies, chemo is systemic and circulating to most body areas. I know they're working through research on targeting certain cells with certain chemos, and I think we'll see that more and more. There are 6 major chemotherapy drug categories: antimetabolites, anti-tumor antibiotics, antibiotics, alkylating agents, topoisomerase inhibitors, and miscellaneous drugs. And those are separated on table 12.2. One thing to remember, antibiotic agents interfere with the formation of certain tubules, so the cells cannot separate during division. So there are different ways that the cells divide, and these agents work on any part of that cell division. Some cross across the DNA, some disrupt the enzyme, certain enzymes, but antibiotic interrupt the formation of the tubular cells. So that's interesting to read over how chemotherapy drugs work. Chemotherapy drugs are given on a regular basis, and they're timed to maximize the number of cancer cells killed, as well as to minimize the damage to the normal cells. So very strict dosing and regulation of the chemotherapy. It's usually scheduled every 3 to 4 weeks for a specific number of times, usually 4 to 12 times. So you will hear patients saying, I'm on number 2 treatment or number 3 treatment. Given higher doses of chemotherapy more often is called dose-dense chemotherapy. So that makes sense. They're going to get higher dose more often. And that's usually when they've gone in there and found that it has metastasized and is at a different stage. Dose-dense chemotherapy also results in more intense side effects, you can imagine. We've talked about vesicants and the leakage of the infusion into the tissue surrounding the infusion site, how to prepare, what to do. I don't ask too much about that because we are not going to be giving that. There are RNs administer chemo, and they have to be certified. But what to do after, you certainly need to know how you're going to monitor that patient very frequently and what you're going to document as far as the IV site. Then we talk about hormone replacement therapy. Hormones, of course, are naturally occurring chemicals secreted by the endocrine gland and picked up by the capillaries and moved throughout our body. Once in the bloodstream, hormones circulate and exert their effects only on the tissues in which they're deemed to affect. Some hormones make hormone-sensitive cancers grow more rapidly, and some cancers require specific hormones to divide. Drugs used for hormone manipulation of cancer are hormone agonists, such as androgen, estrogen, progestin, and luteinizing hormone-releasing hormones. Hormone antagonists are the anti-androgens and anti-estrogens, so they're antagonizing, so they're anti-estrogen, and hormone inhibitors. Hormone manipulation can usually control the cancer, but it does not cure it. One is prostate cancer, for sure. I know they use a hormone therapy a lot nowadays with that. Targeted therapy for cancer takes advantage of one or more differences in cancer cell growth or metabolism that either are not present or are less common in normal cells. These differences result from specific gene activation in cancer cells. Agents used as target therapies work to disrupt cancer cell division in one of several ways. And the different ways, of course, have to do with the different drugs. Some of these drugs target and block growth factor receptors. Others may be antibodies directed against a cellular substance, and so on. They're effective only if the cancer cell has a target for this drug. And if it does, then they can go in there and use that specific cancer for that targeted cell. So we have TKIs, EGFRIs, VEGFRIs, MKIs, proteasome inhibitors, and angiogenesis inhibitors. Of course, there are many side effects, and especially on the skin, mucous membranes, that sort of thing. Vomiting, diarrhea, just a lot of side effects. Immunotherapy is a biological response modifier, or BRMs. You notice they all go by these alphabet letters. They modify a patient's biologic responses to tumor cells. The BRMs currently in use as cancer therapies are cytokines, which are small protein hormones made by white blood cells. they generally help the immune system work better. Two common BRMs used are interleukins and interferons. Those are the two that you hear about. You probably have heard those terms, interleukin and interferons. Interleukins are a group of substances that makes the body makes to help regulate inflammation and immune protection. Some are now made in the lab, and they help different immune cells recognize and destroy abnormal body cells. And then you have supportive therapy. They're used sometimes are the colony stimulating factors. These factors induce more rapid recovery of bone marrow after chemotherapy, because you know during chemotherapy the bone marrow is highly reduced, and that makes the patient more susceptible to other diseases, infections, and that sort of thing. Always our patients need to wear a mask because their immune system is very low. And that's pretty much it. I know it is very deep and very complicated. I've tried to shorten it to make it a little easier for you. But be sure and read the key points. Normal cells divide only when needed, and their growth is strictly controlled. Transformation of a normal cell into a cancer cell involves mutation of the gene DNA of the normal cell. So the DNA is what is messed up, and those cells start dividing and become abnormal cells. The actions of chemotherapy drugs on cancer cells are related to their ability to damage that DNA and interfere with cell division. The normal cells most affected by these drugs are those that divide rapidly, including skin, hair, intestines, spermatocytes, and blood-forming cells. That's why you lose your hair, that sort of thing, because it affects those cells. Regardless of the exact mechanism of action for cancer drugs, the overall results are failure of cancer cells to divide, leading to cancer cell death. So you want to stop that abnormal cell division. Although administration of chemotherapy should be performed only by certified RNs, monitoring the patient, as I've told you, during chemotherapy administration is the responsibility of all nurses. Extravasation of vesicants, as we've talked about, can lead to extensive tissue damage and tissue loss. So very, very important. The most important intervention is prevention for anything, but watch those IV sites. The side effects of chemotherapy that suppresses bone marrow cell formation can be life-threatening and are the most common reason for changing the dose or schedule, because they get their bone marrow so suppressed, then they have to change the treatment schedule. Hormone manipulation can control the growth of hormone-sensitive cancers. And I know I have another friend who has breast cancer, and they tested to see if hers was hormone sensitive, and hers was not, but some are, and then they can go in there and manipulate sometimes those hormones. Not all cancers are the same type, have the right targets for not all cancers of the same type have the right targets for targeted therapy. So if they don't, then they cannot use targeted therapy. So again, go over your quiz, and hopefully this has helped you a little bit. Thank you.